Okay. Thank you for the opportunity to speak today with you guys. So the title of my talk is Endoscopy. I never saw it in training. What is the fuss about and how is it evolving? These are my disclosures. Okay. So when we talk about TLIFs, in general, open surgery, it's an open incision. Usually hospitalization could be 4 to 6 days, perhaps shorter. Significant pain typically, for at least a couple of months. This complication rate is a little high, but I would say like 7% or so for complication rate. Endoscopic, you could do a 1 centimeter incision and a little stab incision, 24-hour hospitalization, minimal pain, usually a 5% complication rate. How many of you, I know all of you are at different stages, at least in practice, how many of you have an endoscopic program? Okay. How many of you feel comfortable doing endoscopic surgery? Okay, a couple. If I gave this talk maybe a couple years ago, there usually would be no hands up, right? Okay. So there's about 2,000 endoscopic cases in the U.S. Annually. Asian, if you go to Korea, almost exclusively endoscopic. But technically, it is more challenging. I think that's evolving as more programs have endoscopic surgery done. It prolongs operative time by 2 to 4 hours, especially earlier on. So the type of endoscopy, just in general, that you could have a uniportal endoscopy or dual portal endoscopic surgery. Dual portal involves 2 portals of entry, one which is a stab incision for your endoscopic viewing portal, which is almost how many, if you do a shoulder scope, similar, right? You have a scope in one side, the other side has a working portal. For the neurosurgeons, it's kind of when you do an endoscopic transsphenoidal surgery. So you have to work on triangulation, making sure that you're working at a certain area of course. The benefit of doing it in a dual portal is that you decouple the endoscope and the surgical instruments. So therefore, it is easier for you to do a endoscopic TLIF. You could do instrumentation, you could do cage placement, things like that. Provides greater flexibility and visualization of the anatomy. So in 2022, so a little backtrack, I'm in practice for about 13 years, and through my training over at Duke and Johns Hopkins, we did tubular surgery, right? That was our minimally invasive surgery. I've been hearing about endoscopy for a while, and I got interested in it, and I finally took the plunge. So I observed Don Park, I know many of you know him, doing endoscopic decompressions. So I went to UCLA, checked out a few of his cases for a day. I think he did maybe 3 cases endoscopically. And, obviously seeing him, and whenever you see these like YouTube videos and things like that, you're like, oh, wow, this is easy. It is actually more challenging when you're actually doing it. In November, I came back. I didn't stay that long with him. I spent a day with him. But in November, I practiced on a cadaver and just working on the triangulation. And then I tried it for the first time. So I did a right-sided L4, L5 forminotomy. It was a very, very, very long case. I was very meticulous with the bleeding. There are many points during the procedure where I felt, hey, I should just kind of abort, and do it open because, it would take me like half an hour or so to do this open. And then in March, I did about 4 cases of decompression. And then in April, I did my first endoscopic TLIF. So first of all, why, right? So I think it ultimately comes down to the patient. It'll make you less efficient operatively, at least initially, but there is significantly less postoperative pain. So when these patients see me back in 2 weeks and I check on their incision, they're telling me that they have basically no back pain. They have, and these are endoscopic TLIFs. There's better visualization. reduction in infection rate because you are continuously irrigating through the area. And also, we've noted that there is a better fusion rate, especially with endoscopic TLIFs. In addition, if you're doing just endoscopic decompression, there is reduction in the rate of iatrogenic instability as well, because you take off less of the facet joint when you are working endoscopically. So that's the why. How? So decoupling the camera through the working port, and also, in my opinion, dual portal has a quicker learning curve since you're using kind of the same instruments and technique that you normally do. And also from an economic standpoint, if you go to your hospital and you ask your hospital, your practice or whatnot, could you please provide me with the capital equipment to doing a uniportal? They probably will be like, well, how much does it cost? And you're saying, oh, $500,000. They probably will laugh at you, right? And say, okay, well, you just want to try this out. Why do you want to have that investment? For dual portal, basically, it's like a kit that's about maybe $200, right? You already have an Arthrex tower. You have the burners already available. So it's not really a big capital investment at all, especially when you're trying to pick it up. So in 2024, I felt like I really kind of got a little quicker when I went to Korea and saw kind of the masters. So I spent a week in Korea. And then I did 30 more TLIFs and decompressions. Then we had the saline shortage, right? Many of you know this, right? Gradually improved with operative time, but operative time was still a challenge. So if I look at my open surgeries in general, these include TLIFs as well as decompressions, and I look at my endoscopic surgeries, it's significantly longer to do endoscopic, as you can see. And then, if you distill, like, why does it take longer? A lot of it is this bleeding events, right? So when you're doing endoscopic surgery, first of all, you have to work on your triangulation. The second part of it is when you have bleeding that occurs, you get this red out phenomena. So that can take a while to actually control, right? You have to obviously coagulate it before it occurs. And also, there's certain tricks to reduce the bleeding rate associated with these procedures. But as you can see, that's one of the big challenges why it's not necessarily adopted as quickly. So, with my research group, basically we worked with our engineers, our biomedical engineers. We created an AI model that creates a real-time bleeding map. So basically, while we're doing this procedure, see that the blue is kind of where all the bleeding is coming out. See that little yellow, kind of that yellow hash? That's kind of where the bleeding point is. And we basically have an algorithm that goes through 12 different steps to determine the causation and the site of the bleeding. So hopefully, you could coagulate that area much quicker with, basically with your burner. This is compatible, and we're right now doing, using it right now at UIC with our patients. And there's no added operative costs, right? So this might help out with getting over that curve. So the benefit of this is that when we did bench testing associated with this, the algorithm error is like 1.19 millimeters. So it's pretty accurate in terms of determining where the location is. This is us in the operating room. On the right, you can see the screen where it tells you where the bleeding is coming from. And then in live testing, the latency of determining where that bleed is coming from and the actual output that you're getting on the screen is 0.06 seconds. So it's instantaneous. So you don't necessarily, there's no delay associated with it. So far, we've done it on 6 patients. The N is increasing, but it seems like it's making a difference in my practice. I feel like I've gotten 89 minutes, as you can see, minutes are saved. So it's getting actually a little quicker than when I do open surgeries. Of course, this is just in my hands. If it's in different people's hands, it probably will have a different result associated with it. Okay. So I would say it's kind of a big leap especially when you're somebody like me that's been in practice for a while and going back and learning a new technique. But I would say that this is a relatively quick learning curve. You could reduce your time. Initially, it takes multiple hours, 6 hours to approximately 2 hours. And patients are happy, right? It's going to benefit your patient population. They're thankful for a minimally invasive approach. There's virtually zero infections and revisions, decent pain scores. It's a powerful technique, right? You could do endoscopic cervical foraminotomies, thoracic decompressions. We've done endoscopic thoracic tumor resections as well for metastatic tumors. And we used minimally invasive carbon fiber screws. We were able to radiate the patient in 4 days after surgery. So, it was a very quick type of timeline, especially for a certain patient population. You could get effective decompression and fusion technique with the flexibility of motion. It's comparable to open techniques in an MIS manner. Relatively quick learning curve and transformative for my MIS spine practice. And also I would say that in addition, the AI algorithm, we were able to innovate in the operating room, which was beneficial as well. Okay. I acknowledge this. Great. Thank you.